Let's talk about rosacea. So rosacea is a chronic inflammatory skin condition that primarily affects the central face, causing persistent erythema, papules, pustules, and visible telangiectasias. It most commonly presents in adults, usually between the ages of 30 and 50, and is more prevalent in women and individuals with fair skin, although men tend to have more severe manifestations. The condition is characterized by periods of flare-ups and remission and can progressively worsen if left untreated. While the exact etiology of rosacea remains unknown, it is believed to result from a complex interplay of genetic predisposition, immune system dysregulation, neurovascular abnormalities, and environmental factors. Several triggers have been identified that can exacerbate symptoms, and these include sun exposure, heat, hot or spicy foods, alcohol, especially red wine, stress, extreme temperatures, and irritating skin product. Now, patients often report flushing or burning sensations accompanying the visible skin changes, and in some cases, you might see ocular involvement, what we call ocular rosacea, with symptoms of dryness, irritation, or blepharitis. There are 4 recognized subtypes of rosacea. There is the erythematotelangiectatic rosacea, ETR, which is characterized by flushing and persistent redness with visible blood vessels. There's the papulopustular rosacea, which resembles acne with red papules and pustules. Phymatous rosacea, which involves thickened, irregular skin, most commonly seen as rhinophyma on the nose, and this is more often seen in men. And ocular rosacea, which affects the eyes. Now, the diagnosis of rosacea is purely clinical, and it is based on the history and physical examination, with hallmark findings of this central facial redness, inflammatory papules and pustules without comedones, and telangiectasias. The differential diagnosis includes acne vulgaris, the malar rash that's seen in lupus, seborrheic dermatitis, and perioral dermatitis. The management of rosacea focuses on reducing inflammation, controlling the flare-up, and avoiding the triggers. The first-line treatment includes topical agents such as metronidazole, azelaic acid, or ivermectin cream, which targets the inflammation and helps clear the papules and the pustules. Oral antibiotics, especially tetracyclines, like doxycycline or minocycline, are reserved for moderate to severe cases or for any ocular involvement. Lifestyle modifications are also crucial. Patients should avoid known triggers, use sunscreen daily, practice gentle skincare routines, and avoid harsh products. In cases where you see prominent telangiectasias or phymatous changes, laser therapy or surgical intervention may be considered. Now, for your board exam purposes, remember that rosacea presents without comedones, and this is how we distinguish it from acne, and may involve ocular involvement or phymatous changes in more advanced diseases. The condition is chronic but manageable, and patient education about avoiding certain triggers and adherence to therapy is key to controlling the symptoms and preventing progression.